So begin with the diagnostic. We all are aware of the water deprivation test, which is considered to be the gold standard for the diagnosis of diabetes insipidus. But it has some drawbacks that leads to the development of further tests. And what are the drawbacks? That it takes around 13 hours. The patient has to be hospitalized. And in case of chronic polyuria, when we give AVP, it takes the long time, like around 3, 4, or maybe 12 hours to get the results. And in case of acquired nephrogenic DI, due to the partial resistance to the AVP, it leads to the higher than expected increase in the urine osmolality after AVP injection, which creates a diagnostic confusion. So that's why it is not preferred and in these cases. So what options do we have other than water deprivation test, as it is the gold standard? So now the people have used starting measuring copeptin levels, but if we see in case of diabetes insipidus, there is a deficiency of AVP, so we can directly go for the measurement of AVP. But the blood level, the half-life of AVP is less as like insulin, so we measure the copeptin levels, which is the C terminal of the AVP. So, and it is a surrogate marker of the AVP. And the better thing is that it gives faster result, and there is no need of hospitalization. We can get the result in less than 2 hours, and it is basically done with the help of a kit. And it is more accurate, like around 97% in distinguishing the polytipsia syndrome and the CDI, which is often confusing in the water deprivation test. So let's see what are the methods that we can go for the firstly, the basal copeptin levels are measured, and the next is stimulate copeptin levels are measured. The method that we use for the estimation is automated immunofluorescence assay, and the kit is BRA HMS copeptin Pro AVP Crypta. For the stimulated copeptin, there are two methods. Either we can go for the hypotonic saline infusion or the arginine stimulated one. For the hypotonic saline infusion, it has to be done between the 8 a.m. to 11 a.m. And the procedure begins with the initial bolus of 250 ml of 3% saline. Then this infusion is continued with a rate of 0.15 ml per kg per unit until we get the target sodium of 150. And we measure plasma osmolality, sodium, urea, and glucose level every 30 minutes. So this is how the hypotonic saline infusion test is done. So it is
so basically the reason that we are doing it like to avoid water deprivation.
We avoid, and main thing is that we do not require hospitalization and
hypotonic saline, so you need every sodium.
Sir, it is we don't we admit the patient and we do it and we discharge it for the
you have to
monitor sodium long time.
So in a way, what I'm trying to say is that when this is stimulation, better you can go for water deprivation again. Then better might be arginine stimulated.
So here the sodium and this plasma osmolality is done like 30, 60, 19, 120 minutes, then it is finished.
It will not increase otherwise, the sodium will not increase. So there would be some very careful, you have to be very cautious.
Yes, sir.
If somebody is already hypernatremic.
So definitely will not go for.
So it is a challenging test, I would say. So this is something for which already a test which you're doing. I would not be thinking of doing this plus doing
so yeah, it is basically done when there is a confusion between like polytipsia syndrome and CDI. And next one is the arginine stimulated. Here the overnight fasting of 8 hours is required, and time is usually started at 8 a.m. Here if the patient is on desmopressin, then it has to be stopped 24 hours before. And before starting the test, the patient has to be in supine position for 30 minutes. And here the arginine is given via intravascular, and the dose is 0.5 gram per kg diluted in 500 ml of 0.9% NaCl over 30 minutes. And the sample is taken baseline, then after 30 minutes, 45 minutes, 60, 90, and 120 minutes, then it is completed.
more like a growth hormone test.
Yes, sir, definitely.
While this would require more careful.
More careful, yes, sir.
Take sodium and everything. So if at all you want to do a stimulated, you will go for the
arginine one.
but
Yes,
that
sir.
availability will be a problem.
And kit also, the kit is expensive. So now there are some studies that support that copeptin estimation of copeptin is better than the water deprivation test. Here we can see for the diagnosis of primary polydipsia versus central diabetes insipidus, the diagnostic accuracy of water deprivation test is 76.6%. Whether if we see the hypertonic saline stimulated copeptin with the cutoff more than 4.9, it is 96.5. And if we take the cutoff of more than 6.5, it increases to 97.9. So in this way, it is better than the water deprivation test. And if we look into the sensitivity also, the sensitivity of hypertonic saline is 93.2 to 94.9%. And if we see the if we want to diagnose the primary polydipsia versus partial central diabetes insipidus, in this case also, the diagnostic accuracy of hypotonic saline stimulated copeptin is 95.2 in comparison to water deprivation test, which is 73.3. And the sensitivity is 87 is in comparison to the water deprivation test.
So what it is saying is that if you look at the water deprivation stimulated, before that, if you look at the indirect water deprivation test,
yes, sir.
In that setting, what it is saying is that positive predictive value is 67%, which basically means that 33% people who you diagnose as DI do not have DI. And water deprivation stimulated copeptin is usual. That's what it is saying. So if at all you have to stimulate, either use the hypertonic saline. They haven't mentioned about arginine yet.
In the next paper, I will discuss that.
What is, if you look at these results, so what it is telling you, if you say this is not DI, 13% may still be DI. And if you say this is DI, 33% will not be DI. Yes, that is what it is coming out of it. But what is the gold standard?
So if we look at this, the gold standard is more looking like a hypotonic saline.
How did they say that this is DI?
So by this hypotonic saline or the water deprivation.
100%. So they must have had some other thing which will say this is DI. Maybe they have established cases or something.
So they have set up the cutoffs of this.
So when you say this is DI,
yes,
and this is not DI, that is the truth.
Yes,
gold
sir.
Standard.
Yes,
so sir. How did they come to that gold standard?
Sir, this is not discussed actually.
So basically, there must be some way they might have established cases that they were using, or so that would be the most appropriate one. Because otherwise, if you use hypertonic cutoff, then of course they will have a better diagnostic validity. But what we are getting out here is that many patients who are labeled as DI do not have DI.
Yes, sir.
That is the point I was talking about. If you give them AVP, they will develop hypertension. That is the biggest thing. And that is very true for partial DI. That is like more than 50% whom you say partial DI are not DI. Not DI. That is why a lot of us do not think that partial DI is like DI. It's like some vague term. It's not really true. So that's why I talk always about 300 osmolality is a much more better figure than 600. Yes. Because a lot of cases you will start picking up with that.
So coming to the, they have draw this ROC curve, and they have seen that this hypotonic saline infusion, it has a area under curve of 0.9%, and they have set the cutoff of 4.9 and 6.5. But in case of indirect water deprivation test, the area under curve was only 0.65%, only 0.65, and they take off the cutoff of 9%.
What does it imply? When will you say this is significant? If I say area under the curve is 50%, what does it mean? More than 0.5, 50%. 50% is slip up.
It could be the goal.
Yes. So it's at least 0.7, 70%. And if it is this high, it means it's a very good test. So this is not a useless test. The second test is useless.
Now, if we look into the arginine stimulated copeptin measurements, and here are the studies, what they say. In the patients with the partial diabetes insipidus, and they have compared the level of copeptin concentrations in the patients with partial diabetes insipidus with complete diabetes insipidus and the patients with primary polydipsia. And if we can see the level of copeptin levels, it is more in the cases of this patients with primary polydipsia, and it is less in the patients with complete diabetes insipidus. And they have drawn this ROC curve, and they have seen that the at 60 minutes, like we say, what is the right time to get the cutoffs of growth hormone. In the same way, they have seen that at the 60 minute, they get the cutoff of 3.5 picomole in both the development cohort, in the validation cohort, and when they have combined both development cohort and the validation cohort, they also get the cutoff of 3.58 picomole of copeptin. So for them, if we want to take a single sample, then 60 minutes is the best one. And if we get it to 3.8, then we can stop the test.
And so these are all adult studies.
Yes, sir. So, and some studies have combined both these approaches, that if the baseline copeptin level is less than 21.4 picomole per liter, definitely go for the arginine stimulator, because we have this confusion whether it is a primary polydipsia or the complete or the partial. And in the arginine stimulated copeptin, as sir has said that it is more safer, so we should ideally go for arginine stimulated. And if the stimulated copeptin is less than 3.8, as we have seen in the previous paper, the cutoff has been set of 3.8. If it is less, then it is complete or the partial GI. And if it is more than 3.8, and it is definitely a case of primary polydipsia. And if the copeptin level is more than or equal to 21.4, then it is a case of nephrogenic GI.
It's a bit of a confusing result. So if I go like the growth hormone test model, what the model is suggest? If you think this like a growth hormone deficiency,
so if we
do a basal growth hormone.
Basal growth hormone.
If growth hormone is more than 5, then probably you don't need to do the stimulation. So there is the cutoff 21.
21, yes, sir.
But what is strange is that after stimulation, the cutoff is lower. You expect that after stimulation, it should go up. So what they're trying to say that suppose your baseline copeptin is 6, doesn't matter. After stimulation, you use 3.8, you start seeing that they have DI. So this is a bit of a confusion.
So this is a central DH of copeptin will be higher.
Copeptin is low, huh?
Copeptin is low.
In CDI, how it will be higher?
So that's the point. So why are they using such a high level of basal? Which my perspective is that for NDI versus primary polydipsia, that 21 will be the figure. So first they are ruling out NDI.
NDI, yes.
If your basal is very high, that is NDI. If your basal is not high, then they want to use that. Better way would be to also look at unstimulated copeptin in both primary polydipsia versus DI.
So the unstimulated will be the basal copeptin levels.
Yes, is there a difference? They haven't studied that.
No, sir.
Baseline copeptin.
This is the baseline 21.5 is the.
In DI, that is quite more than 21. Right?
Yeah.
But it is not in the normal people. If I do base, the copeptin level of mine
what
will not be 21.
So the question is, 121.4 distinguishes between a nephrogenic DI and everybody else.
Everybody, normal people will have more than 21.4.
Can you also differentiate? So this is central DI, and this will be primary polydipsia, and this will be nephrogenic.
Yes,
nephrogenic DI is all. But do we have too much overlap between central DI and nephrogenic DI? That's why they are using the stimulation. So they haven't mentioned but about the baseline to diagnose the central
DI. Yes.
And that is why they are done. So they have first ruled out NDI using a basal one, and then they are classifying. So you can think of that. So what they are saying is that basal has no role in differentiating primary polydipsia, and this you have to stimulation.
So if we see in the this previous, So when the test is started, it started with a 4.1, then 3.8, 3.8, 4.0. This is Arjun.
That is after 30 minutes.
After 30 minutes. So
already stimulation.
already stimulation, but they haven't mentioned the 0 minute.
Yeah. So if they had mentioned 0, we will know.
So if we look into the chart, there.
So there is no difference.
No difference.
So if you look at 0, there is a difference, and this is 2. So what you see, this is the complete complete DI, this is partial DI, and this is the one
polydipsia. Yes,
so
sir.
this is much higher, but there is an overlap. That's what they're trying to say. And if you carry forward subsequently, the least overlap is at 60 minutes.
Yes, sir.
This is like overlap is no overlap basically if you look at it. While again the overlap, that's why the 60 minutes is more important. So what they're saying is that basal average values will be different, but there will be many people who have primary polydipsia who have low AV. Primary polydipsia low AV. Why do you think primary polydipsia can have low AV?
One of the etiology of primary polydipsia is actually the activation of THARS because of the AVP stimulation. So if THARS increases, patient will take more.
What will happen to fluid status in primary polydipsia?
It will be more.
What will happen to
osmolality? Low. Osmolality will be low.
So AVP will be
suppressed.
Low.
So that's a very important point. Now we can get it that if you have primary polydipsia, your AVP may be low. And that is why you cannot distinguish using the baseline. And then you do that. So the concept is very clear. The baseline is only to differentiate nephrogenic versus other. Once the baseline is non-nephrogenic, then you have to do a stimulation. So baseline copeptide has no role because primary polydipsia, your AVP may be low.
And the one thing they have mentioned that in the unclear cases.
Yeah, so if you go on don't go into that, but if you look at the first study, the diagnostic accuracy was much higher.
Yes, for the hypertonic saline.
So that is why hypertonic is the gold standard, that's what they're saying. You can use the arginine in most cases.
Most cases, because it is the safer.
Where we are doing only based on hormone to rule out that.
Yeah.
Because there is no.
So that's NDI.
That's NDI.
That's what I started with that one. But then I said this 21.4 is too high compared to 4.8. So only role of basal copeptide is to identify
nephrogenic. So moving towards the term antibody, which is quite new and unique to me, that is anti-raphelin 3 antibodies. And there is a study that shows that the absence of anti-raphelin 3 antibodies in children and young adults with idiopathic central diabetes insipidus is a potential clue to elucidate a tumor etiology. Let's see what does it say. They have presented a case of 2 children, one is children, one is adolescent, and they presented with the features of diabetes insipidus. They have polyuria, headache, vomiting, and they were diagnosed with idiopathic central diabetes insipidus. And both the patients developed panhypopituitarism. And during the beginning, their MRI was normal. There was no stalk thickening, but later on, after 1.5 years of the onset of the eye, the stalk thickening develops. So there was quite a dilemma at the initial presentation whether it is a immune hypophysitis or the other thing or the cellular. So and when the investigations were done in both the cases, what they have found that the AFP, beta SCG, both in the plasma and the CSF were in the normal range. So it again increases the suspicion what it is, whether it is because in the germinoma these levels have to be elevated. So they were diagnosed as this autoimmune diseases, but these are the images during the admission when there was no stalk thickening, and later on after 15 months they developed stalk thickening. So for these patients, they ran the blood samples and they get the anti-raphelin 3 antibodies, and it was negative.
What is this against?
So this anti-raphelin antibodies is present in the, it is against the AVP neurons. It is present in the posterior pituitary gland. So if these antibodies are present, so definitely it is an autoimmune condition.
For
AVP.
So then this is going to be going more in favor of a scenario of autoimmune.
Here,
I had done earlier studies in which they said that the anti-AVP antibodies are non-specific.
Yes.
They are not good in terms of the overall prediction of autoimmune. So is this more specific compared to the anti-ABP antibodies?
So they have not mentioned about the anti-ABP antibodies, and this is very specific because I'm going to show the next paper. Here it comes negative, then they have made the diagnosis of germinoma, and when the biopsy was taken, then it shows the germinoma cells, and they were treated like germinoma. Now, coming as the sir said, whether it is specific for, yes, it is a specific. The Raphelin 3A antibody as targeted autoantigen in lymphocytic infundibulous neurohypophysitis, which is initially most of the idiopathic causes are this infundibulous neurohypophysitis. So they have shown that the Raphelin 3 antibody is a major autoantigen is in LINH, that is lymphocytic infundibulous neurohypophysitis, and it is serve as a biomarker for the diagnosis of LINH and is the useful for the differential diagnosis in the patient with CDI. And it is expressed in the posterior pituitary and the AVP neurons in the hypothalamus, and this, if they are present, that definitely it is a case of autoimmunity. And here they have done a study where they have seen that in the cases of biopsy proven LNH, all of the 4 children were antibody positive. In the clinically diagnosed LNH, some 18 were positive and 7 were negative. In the biopsy proven Langerhans, only 2 were positive because they are not supposed to have antibodies. In the biopsy proven supracellular and cellular mass, none of the antibodies were there. In the other autoimmune diseases, antibodies were there. In the healthy control, can also have antibodies. In the idiopathic DI, as I have already mentioned, that in most of the cases of idiopathic DI are the cases of lymphocytic infundibulous hypophysitis. So definitely it is a marker for the diagnosis.
What you are saying is that if somebody has DI, there is stock thickening with normal HCG and AFP in blood and CSF, you should do this.
Yes, sir. And if it is positive,
is negative, then you have to be very cautious.
Yes, sir.
Would you do a biopsy immediately? What are they saying, or wait for time?
No, sir. The biopsy is like if 3 monthly, or as we have discussed in our protocol, it is in the same manner.
Then so this is a very major issue. As I discussed in the talk, was that you have to distinguish between autoimmune versus germinoma. So the conventional teaching is anti-ABP antibodies are non-specific, so you cannot use them. So maybe they are a better agent that is right. Second is you see the pituitary mass.
Yes.
There is the anterior pituitary shrinking, that is hypophysitis. It's expanding, it is germinoma, but that will be too late. So maybe what they are suggesting is that if you have stock thickening which is significant and progressive, negative HCG, AFP tumor markers and a negative antibody, biopsy will be something which is helpful because those 2 cases have 0 AFP and HCG.
But before biopsy, we can go for this antibody as
that's
well.
Why I'm saying the antibody is negative.
Negative, yeah, definitely for the germinoma. Now coming to the novel therapeutic agents, sir had mentioned molecular chaperones. The vital role of this is the stabilization of unfolded proteins, and they rescue the mutant V2 receptors, and they take the V2 receptors to the cell membranes and increase their functioning. They have also used the clopidogrel, which is a P2Y12 inhibitor, which activates the G protein coupled receptor, as this V2 receptor is a G protein coupled receptor. It inhibits the cyclic AMP degradation, and it has shown some increase in the urine osmolality in patient of X-linked NDI. But there is only single study, and we cannot say whether it is useful or not.
You don't want to comprehensively increase cyclic AMP in all cells. Cyclic AMP is a major second messenger. So if it is going to work everywhere, you don't know what is going to happen. So what you're looking at, something which can really increase aquaporin. I think that's the most important. Or the one, there is that V2 receptor becomes more, or aquaporin becomes more. Because this is not going to be a good strategy. Like metformin. Who's going to use metformin for nephrogenicity? It's just that experimentally it has been shown to be effective. But then if you increase cyclic AMP, what will be the side effects on so many organs? So you have to be careful.
Another, it's double-blind RCT was done with the atorvastatin, and on the patients on lithium therapy, they have used a dose of 20 mg, but it does not show any improvement in the urine osmolality. It was just a trial, so it is not of much use. Again, as the sir has mentioned, that the metformin, stimulated the AMP activated protein kinase, and it could be used, but it is not of much use. Then I think this is a novel therapeutic and still is in trial, that targeting miRNA 137 and microRNA 32 as well as the topomycin 5B, which are essential for equiparent trafficking. I think that will be useful to treat DI, but still under trial. Another one is ACAP PK disruptor. It is a low molecular weight compound and it increases the equiparent activity. So, and to the same as vasopressin. So, it is a potential therapeutic drugs for the treatment of the NDI. So, these are the newer.
You want drugs which are very specific to that particular region.
Yes, sir.
So only either extraporin or
this one.
These two will be the only ones which are there. But it is not going to be easy. How do you stimulate there? In those cells only, it's going to be a challenge. And all these drugs which are used in other places like atorvastatin. So suppose atorvastatin is going to be good treatment for DI. What do you expect atorvastatin to do in a normal individual?
It will decrease SIDH.
So do we see that? Which means it is not really going to be an effective one. Some people have used like, how was diazoxide identified as an anti-inflammatory?
Initially used in the treatment of the baldness.
What?
Baldness?
Initially treatment as a hypertensive.
Anti-hypertensive.
And then it got hypertension.
Yeah.
And because of that, people thought that if you treat an hypoglycemia, it will be effective. So this is what is called a serendipity.
Yes.
So if you have shown that atorvastatin causes SIADH, then somebody will think, okay, atorvastatin causes SIADH, then I can use atorvastatin in DI. So these are all theoretical, but I think
but this the last one, ACAP PK, but this can be used if it is
these will be there, but then these are not going to be easy to use. I don't know. It is like
but
something like
these are under trials.
They will go into the cell and then they will disrupt. So this needs some study, and the patients are so less that you will not get very easily available. If you are not using copeptin, still remember that water deprivation test is not 100% test. It is giving you an indication. Many patients whom you are saying are DI are not DI. And many who are excluding DI are not actually they are DI. The other thing always many older people who are managing used to say that even if you diagnose somebody as NDI, give them a trial of desmopressin. Because they may actually be central DI and your criteria of 50% has not picked them up. So there is no harm in giving somebody whom you are presumed to be NDI for some time, 2 days, 3 days, and then if they don't respond, you think of, okay, this could be there. The other thing is that be very cautious when you're giving AVP to somebody who is diagnosed as DI based upon water deprivation test, because he may not be DI. And maybe a week later, they will develop hyponatremia. It could be a compulsive water drinking.